Are you looking for a school with a safe,
Ask the
friendly,
Surgeon,
and family?
brought to you by Everett Bone and Joint. Everett Bone and Joint, the best choice to get you back in the game. Learn more at everettboneandjoint.com.
All right, welcome to Ask the Surgeon, part of Health Matters. I forgot where we were there for a second. Brought to you by Integrated Rehabilitation Group. Well, joining us is the brand new doc at Everett Bone and Joint. You might have heard him. He was the star of the Everett Bone and Joint Roundtable from a couple weeks ago. Dr. Doug Nowak joins us. Welcome.
Thanks, Maury. Thanks for having me.
Now, when we were in break, you told me that a couple of years ago you worked in Colorado and you worked with doctors that performed hamstring surgery on Peyton Hillis, right? Is that what you said?
Well, right. Well, Peyton Hillis had gone through the Semin Clinic about a year or two before I was there. He actually had a complete tear of his proximal hamstring, so where the hamstring attaches to the pelvic bone, it had torn off. And Dr. Philippon, which is the doctor that taught me how to do hip arthroscopy, had performed the surgery to repair those tendons. This is about 2 or 3 years ago when he was still in the Broncos, and then went on to have his breakout year with Cleveland last year. So he presumably had a full recovery, but now it looks like I'm not sure if he injured the same hip or the other hip. It's not really clear from what I've heard.
Maury, you
so
just
far.
said they were doing an MRI,
Yeah.
and he may have to undergo surgery.
Right.
Okay.
Yeah.
So usually, like we were talking, surgery is usually indicated when the completely avulse or tear the hamstring off the attachment point.
Right. So he may just have, a partial tear or strain of the hamstring.
Right.
And, so we're not.
Don't know yet.
We had no idea whether it's going to lead down to surgery or not.
Do you think they're doing an MRI because of his history with, from the surgery he had a couple of years ago?
Probably.
Yeah.
Probably.
Okay.
So, you brought up a point regarding your training. Now, just so those people out there listening understand, you trained at the Stedman Clinic, and you trained underneath Dr. Philippon?
Correct, yeah. Dr. Mark Philippon is really the unquestioned leader in hip arthroscopy, a high-level athlete. So if you look at all the recent Seattle athletes that have had hip surgeries, like Sidney Rice when he was on the Vikings, Sue Bird, Lauren Jackson of the Storm, David Aardsma, before he had his Tommy John, they all had the hip arthroscopy done by Dr. Philippon this past year.
A-Rod, too?
Well, A-Rod, yeah.
Uh-huh.
A-Rod a few years ago. Marty Lemieux, Greg Norman, Tyson Gay, a bunch of high-level,
These are elite athletes.
Right.
That, just to catch people up, hip arthroscopy is a procedure that's been around for a little while, but you're performing it. You're the only orthopedist in Snohomish County that actually does the arthroscopic procedure of the hip. Is that right?
Right. I'm the only one that's have the training because it's definitely a more difficult surgery than doing knee or shoulder arthroscopy, which a lot of orthopedic surgeons do. The hip is it's a much more tight joint to work in, and so it needs special training in order to do it safely and effectively.
Okay, here's my stupid layman question. Is it harder to do than hip replacement surgery?
Yes. Okay. I think if you look at my residency, so I did 5 years of residency at Columbia University in New York, Manhattan, which is a really well-respected orthopedic department. I probably did, 250 hip replacements during my training, but I didn't do a single hip arthroscopy in 5 years. And then when my year in Vail, I was involved in 100 hip arthroscopies with Dr. Philippon just because he does so many because people seek him out from around the world.
Well, you have to understand the anatomy of the hip joint, too, and it's a very tight joint that's difficult to get the scope or the camera and the tools into that joint so you can work at. And plus, anatomically, it's just difficult to maneuver in there.
Right. So the hip joint, in order to do the surgery safely, you actually have to distract the leg, meaning that we put about 50 to 70 pounds of traction. So just picture someone pulling at someone's ankle, 50 to 70 pounds of force to open up that hip joint, and I open it up about a centimeter, and then my instruments are about 0.5 millimeter, so I'm working with 0.5 millimeter instruments in a centimeter space, and you definitely have to be very careful so you don't damage any structures in there, and that's why not many people do the hip arthroscopy because they're not comfortable. One, they haven't had the experience doing them, and they're not comfortable working in such tight, confined spaces.
They give you anesthesia for this too, right? They don't do it.
Let you bite on an apple or something.
Yeah,
like that.
bite on this.
So here's what's interesting is we're starting to hear and see and read more about these procedures, particularly in the hip, because the scopes have been around for a long time with the knee and then the shoulder. But as advances increase, what kind of things are you treating? What kind of pathologies are you helping with these days?
Right. So what you normally read about in the paper is that, so-and-so has a labral tear. and they're going to Vail, Colorado to have a surgery if it's an athlete. So labral tears. So the labrum is fibrocartilage. Think of it as a soft tissue bumper that goes around the socket of the hip joint, and it helps to basically protect the cartilage, and it serves several other functions that help basically protect the cartilage of the hip joint and help the dynamics of the hip. So that frequently is torn, and that's the most common reason that these athletes end up having hip surgery. But typically the reason it's torn is because they have a condition called femoral acetabular impingement, or let's just call it hip impingement to be simple, where they have a little extra bone around the hip joint, the ball and socket, and sort of picture it like a square instead of a ball trying to fit into a round socket. So you got a square trying to fit in a round socket. It's not going to fit well, and those edges will impinge on each other, and the labrum gets caught in between and gets torn. So that's the most common scenario that ends up having surgery. So what we do is arthroscopically through 2 or 3 small incisions, you're able to go in, repair that labrum back down, and also remove those bone spurs so they're no longer impinging on the hip. Because if you go in and fix the labrum, but you don't get rid of that impingement, the labrum either is not going to heal or it's going to re-tear. So you really got to address both of those at the same time.
Now, genetically, are there just people that are born with these femoral acetabular impingement kind of problems?
There definitely is a genetic predilection. There's no question about that. But there's also activity-related as well. Like, it's definitely very common in hockey players because of the way that they push off. So that's definitely one of the more common sports that you see it. And then just because you have the impingement doesn't mean you're necessarily going to get a labral tear. So if you have that impingement, but you're a couch potato and you're not really moving your hip around, you're probably not going to tear your labrum. So you need to have the impingement plus do a lot of activity. Occasionally, like in the case of Lauren Jackson, it was one specific injury that tore her labrum when she did one specific maneuver on the court. But usually it's more of a repetitive process of the thousands and thousands of times of moving your hip into position and those bones impinging that the labrum tears.
And A-Rod, baseball players, is it their swing? Is it
probably the swing? The twisting on it. But some of it also is the training, deep squatting and deep lunging. When you really flex that hip up, those bones impinge on each other and could tear the labrum. So it could be the swing, could also be just off-season training.
Now, this is another thing that you hear this a lot. I mean, it seems to be the chic injury that's going on right now, and the arthroscopy surgery. They're getting back quicker. Is that?
Well, it's an elite athlete. You will take some chances and get them back quicker. So in the case of A-Rod, he hit a home run like 30 days after he had his surgery.
Yeah, I don't know if he's 100% all year, though.
Right, and Marty Lemieux was on the ice 17 days after he had his surgery. This was over a decade ago.
Yeah. So is it advanced over a decade ago? It's probably better now than it was a decade ago, right?
Yes, I think we have a better understanding of it. We have the equipment has definitely advanced. I still, for say my normal everyday person, non-professional athlete or my high school athletes, I'm going to go pretty slow with the rehab. When you're Marlon Lemieux or A-Rod, you will take the chances because you're getting paid millions of dollars to do what you do.
Well, don't they also have all day long to rehab where, just the normal person doesn't have all day? You know what I mean?
Right, right. Yeah, and in Vail, when the athletes come through, they rehab like 2 or 3 hours in the morning, 2 or 3 hours in the afternoon, and in between they're riding their bike or in the pool. So, most of my patients don't have that luxury.
Sure.
And in which case, it's really, to get back to a full contact sport from a hip arthroscopy, really 4 to 6 months you're looking at. That 30 days that A-Rod did is really unheard of unless you're A-Rod or someone like him.
How would someone know that they might have femoral acetabular impingement or a labral problem in their hip? I mean, let's talk about signs and symptoms, and let's talk about mechanisms of injuries.
Right. So the classic sign is pain deep in the groin. So the front of your hip, you get this pain that's sort of nonspecific, this achiness. When you get in certain positions, like if you squat down or if you sit in a low chair for long periods of time, you will start getting this achiness, sometimes even a sharp pain there. Long car rides, long plane rides, you get this achiness in the hip. That is consistent with the labral tear. But now there could be some other causes.
I think I have a torn
labrum. yeah. Here you go.
I'm aching just sitting here talking to you guys.
Let's do that on the air. Let's do that surgery on the air.
But so it's not, is it not in the pain you don't feel would be in your hip, would it be in the groin, or would it be in both places?
Well, when people say hip, it's sort of...
Oh, yeah.
I try not to use the term hip because sometimes they, the hip, they're pointing to their butt. Sometimes they're pointing to their back.
Or the side deal right there. That's what I think the hip is. But I'm wrong, aren't I?
Yeah, that's a little higher.
Yeah. Well, there's a lot of differential diagnosis here, and the thought is that chronic deep pain in the groin, which is on the inside of your thigh.
Yeah. The inside or the front.
Or the front.
Classic
right.
is where it's going to be. Now, occasionally you will get pain on the side or the back, and when that's the case, when someone comes in with just pain on the side or the back, it's usually more of a confusing diagnosis, and they have to do a couple more steps to work it out.
Right.
And then, as opposed to when someone comes in with a classic pain in the front or the inside, and then I get an MRI, I see it. It's no
Do
question.
they have night pain? I mean, trying to sleep at night, no discomfort?
No. I mean, they may have some discomfort, like at the end of the day, just because some achiness of doing a lot of activity. But rare is it that you'd have pain that would wake you up.
Okay,
that's a big thing, isn't it? Night pain.
Night pain. You always want to.
That's when you know you're in trouble, right?
Yeah. Well, you want to have any kind of night pain or consistent night pain. You want to have looked at. Do they have any snapping or popping, clicking, catching? Like sometimes when we talk about internal derangement of the knee, we talk about those symptoms: snapping, catching, popping, locking. Anything in the hip going on?
You definitely can. You definitely can get what we call mechanical symptoms, all the symptoms that Shan just described. And typically those, again, are going to be sort of deep in the hip. They can be caused both by a labral tear as well as tendinitis of some of the tendons that overlie the hip joint. And those tendons sometimes are inflamed and snap independent of labral tear, but oftentimes they're inflamed because there is a labral tear. So that's...
Yeah, I mean, what comes first, the injury or the result of the injury?
Right.
I think
We're let me just fill everybody in. What we're doing
absolutely.
Here. We are. This is the Ask the Surgeon segment, brought to you by Everett Bone and Joint. We're talking to the newest Dr. Doug Nowak. He's an orthopedic surgeon. We're talking about hip arthroscopy. I can say this with my eyes closed, not on the radio.
Arthroscopy.
Arthroscopy. Oh man. We're out of time. Sorry about that.
No, all we need to know is what folks need to know. Again, we're talking about minimally invasive surgery. You have 2 or 3 poke or holes or access points in your hip. You're going in there so you have a labral tear. What are you doing? Are you debriding it, taking it out, removing it, repairing it? What do you do when you go in there?
So when people first started doing hip arthroscopy, they would do what's called a debridement, which basically means cleaning up, removing the frayed tissue. And actually, when they first started, they were very aggressive about removing almost the entire labrum. Now, what we found, if you look back at the history of knee surgery in the 70s and 80s, the surgeons used to remove the whole meniscus. And then 10 years later, a patient would have bone-on-bone arthritis because that meniscus serves as a protective layer to the cartilage. And so the labrum in the hip is somewhat similar to meniscus. It's not exactly the same, but it definitely has a cartilage protective function. And so there's a concern that if you remove the whole labrum, that may lead to problems down the line. So I'm a big proponent of saving the labrum and repairing it. Basically, using suture anchors, I'm able to tack that labrum back down to the bone. Think of it like a tack that goes into the bone, and then a string that I use to loop around the labrum, and I could tie that to put the labrum tightly back on the bone.
And that labrum will reattach and heal back to the bone?
Correct, yes.
So it has a fairly good blood supply then?
Right. Well, there's certain things that I need to do to help promote that.
Right.
I need to make sure that I roughen up the bone so the bone is bleeding, and then as long as you got good bleeding on the bone, that blood will bring healing factors to heal that labrum back to it.
That's pretty interesting, isn't it?
It is.
I mean, it's fascinating that they're doing this surgery through scopes on a TV monitor, and there's 2 or 3 holes. I mean, I don't want to use the word kind of crudely, but I mean arthroscopic portals. Mm-hmm. But did you find that playing video games as a kid has helped you improve you as a doctor doing that type of surgery? I want him to say yes. Yeah. You're thinking you have a
yeah, I could be a doctor.
You play a lot of Xbox.
I do, as a matter of fact.
Not really for this type of surgery. There are certain surgeries, some of the robotic surgeries, I think it could, but not for this.
It's just incredible what they do now, and it's it's doing that, and then knee replacement and hip replacement. Nowadays is so common. Everybody's getting a hip and knee done,
Well, think about how many people probably sustain this type of injury because people have doing sports and running and being active for a long time and just had to live life with this deep pain in their hip and groin. And they probably end up with, I would guess, if you change the joint structure and mechanics, you probably end up with a little bit of arthritis in that joint.
Right. If you look at the patients that have had total hip replacements, they've done some studies in Scandinavia, and they found that 80% of them had evidence of the impingement. So presumably they had the impingement and a labral tear, and eventually it led to arthritis, and they had the hip replacement. So there's no question that the hip impingement and labral tears have been shown to be correlated with arthritis. So what we're trying to prove now is looking at more longer studies of our hip arthroscopy patients and seeing if we could either stall or at the very least slow down the progression of arthritis in the hip by removing the impingement. So I can't make that claim right now, but hopefully in 5 or 10 years we'll be able to show that the hip arthroscopy is slowing down arthritis of the hip.
Who are you seeing here, having this surgery? I mean, you're not seeing any world-class athletes, but are you seeing,
Sounds like you're going to be signing up.
Yeah, I know. Just for the show, for the sake of the show, what the heck, right?
I've seen a wide variety of people. I mean, I've seen some, high school kids that have it, and they're the ones that really do the best because they're young and they're healthy. They haven't had the impingement for long enough to have sufficient cartilage damage. And if you're able to basically have the surgery done and repair the labrum before any significant cartilage damage occurs, then those are the patients that do the best. I've definitely seen some people, in the mid to late 20s. Again, they have maybe a little bit more cartilage damage. But then I'm seeing a lot of patients in their, late 30s and 40s, even 50s, who don't have enough arthritis yet to warrant a hip replacement, but they do have some arthritis because of this, long-standing hip impingement. So I'm seeing all variety of patients.
And it should be kind of stated that you don't have to be an athlete to have a hip or a femoral acetabular impingement. I mean, you can just have that genetic predisposition to that cam or that bony or square bone you talked about.
Yes, true. I mean, we definitely see the tears more in probably athletes than non-athletes, but we definitely a lot of activities can do, and a lot of manual labor jobs that involve a lot of deep squatting, picking up heavy machinery or doing a lot of crawling or climbing ladders. That puts you in a position, just like the athletes do, a lot of hip flexion, and that doing that thousands and thousands of times over your job career could definitely lead
repetitive trauma. Again, it's repetitive trauma. What is the outcomes and return to, let's say, not just sports, but generally return to function?
Okay, well, I'll start with the sports because that's probably the most demanding. Is 4 to 6 months if I have to do a lot of bony work and repair the labrum. It's 4 to 6 months to get back to, say, playing football or baseball, or not baseball. I mean, like soccer, some more, a lot of pivoting type activities
for high school kids.
High school, college, pros,
and
pros will be a little quicker because you'll take the risk, but that's a different story.
Okay.
You're on crutches for 4 weeks after the surgery, and then after those 4 weeks, then you'll start progressing your activity. So if you do a desk type work, you could go back to work, after a week or so once you're comfortable. But if you're doing a manual labor type job and a lot of lifting, squatting, that if it's really, really heavy duty, that's going to be 4 to 6 months. If it's a job that's not a lot of heavy lifting but a lot of walking, probably about 2 to 3 months. So it's individualized depending on your job duties and also how you recover. Some people just recover quicker than others.
And do most of these people recover and go on to do activity and they don't have that deep pain in their groin anymore or that mechanical clicking, popping in?
Right. That's the full expectation, is that you get back to a normal activity. Now, the only caveat is that if you come and you already have significant arthritis, I'm not going to be able to reverse that. But I may be able to do some things that at least make you feel better and function better. But if you have significant arthritis, typically you're still going to have some discomfort, but hopefully at least be able to make it
But you have
better.
some resolution of some of your symptoms, hopefully. Now, and prior to surgery, you're doing an MRI just to rule in and out this impingement?
Correct. You look at X-rays, and you can see the extra bones on the X-rays, but then you look at the MRI to look at the state of the cartilage as well as if there's a labral tear or not. And
just I can hear the music in the background, just so those folks listening also know, this is your specialty, but you're also, your interest is in sports medicine. You do arthroscopic procedures for shoulders, knees, hips.
Yeah, but my main clinical focus is shoulder, hip, and knee. Management of sports-related injuries and, non-sports-related injuries. And surgery-wise, primarily arthroscopy. I trained with some of the leaders in shoulder arthroscopy up at Columbia, New York, as well as Stedman Clinic.
Wow. And where are you from?
Chicago area.
All right.
Been all over.
The Bears.
Everett Bone and Joint. They got great doctors. For more information on the doctors, go to everettboneandjoint.com and go to our website.